Good afternoon, everyone. My name is Ailey Peterson. I'm the Vice President of Brattleboro Memorial Hospital. I help to oversee our medical group practices and population health for the hospital. And we're here today to share with you all our vision for oral health care in our respective communities, in the region, and in the state. And I think what you'll find in our presentation today is that we're really working to embody the spirit of the theme of this conference. So we've got a group of people who are very passionate about oral health care and committed and making promises to the community about how they are going to achieve that mission. We're also going to share with you collaborative and innovative approaches to meeting the needs of the community. And I think it's really interesting that we have 2 hospitals, a technical college, and a United Way. And typically, with those groups of organizations, you wouldn't usually think about dental care. So it is a really unique, I think, innovative approach to, again, meeting the needs of our community. So you're going to hear from some very passionate folks today who've done amazing work in their areas. Carmen Derby, who's the Executive Director for United Way of Windham County. Jim Tremarky, who's the Director of Planning with Southwestern Vermont Healthcare. And Dr. Cheyenne Warner, who is the Dental Director for the Dental Therapy Program with Vermont Technical College. And so to start out, I'm going to talk with you all a little bit about Brattleboro Memorial Hospital and our role in the work of public health dentistry in our community. So BMH, we are a small hospital, rural hospital focused on community health care. We're not quite small enough to be a critical access hospital, but small enough where we all know each other. We have great working relationships with our patients. And one of the things I'm really proud about our particular hospital is that we're focused on the care of the community. So our vision and our work is much more than just what happens within the 4 walls of a hospital, but what does our community need? And what is our community telling us that they need? And then working hard to figure out a way of how to meet those needs. So like all hospitals in Vermont, we have completed our community health needs assessment. The last 2 iterations of our community health needs assessment identified for us that our community was in need of access to dental care. It was in the top 5 listings of unmet needs for our community. And those particular needs fell into patients who were adults who were on Medicaid, or patients who were uninsured or underinsured. Those were the folks who were telling us they could not find access to dental care. Part of that is exacerbated by the challenges with Medicaid reimbursement in Vermont, although it's certainly not unique to Vermont. Right now, a adult patient who is on Vermont Medicaid receives a cap when it comes to payment for Medicaid, and that's $510 a year. And to help put that into context, that maybe covers the cost of 2 fillings. It does not cover the cost of the recommendation of 2 dental cleanings per year. And it certainly would not cover what we see mostly from patients who have gone their whole lives without access to dental care, which is a full mouth restoration. It doesn't come anywhere near covering the cost of that, or extractions, or dentures. And so it's a result of those challenges that private practice dentists struggle to be able to accept patients who are on Medicaid, adult patients. We also saw the need in our emergency room. Like many hospitals, I'm sure you see these needs as well. But we had patients presenting to our emergency room who were in need of oral health care. And as we all know, the emergency room is not the right place for a patient with oral health care needs to get their care. What happens with these patients who show up in the ER is that their symptoms might be treated. They might get pain meds, which is another problem. They might get antibiotics if they have an infection, which is great, but they're not having their teeth fixed. They're not having their true oral health needs met. And so these patients present again and again with these same problems. And in our community, it's because they had nowhere else to go. So it's an inappropriate use of the ER. It's also an inappropriate use of healthcare resources. This is not where we want to be spending our funds in the emergency room. We also performed a secret shopper. We made calls to private practice dental practices within 100 miles of our community. So we looked in Vermont, we looked in Massachusetts, we looked in New Hampshire, and no dentists were accepting adult patients who were on Medicaid, new patients. None of these dental practices had sliding fee scales or offered charity-free care. So when you think about access, really the only place that these adult patients on Medicaid could go when they had a problem or when they were in pain related to oral health care was the ER. So all of these things helped us as a hospital determine that we had a need and we needed to do something about it. So way back in 2016, we as a hospital partnered with United Way of Windham County, who you'll hear from Carmen in a little bit here, was also doing a lot of work around oral health care. And we partnered to convene an oral health task force to look at what can we do to make a difference. We brought in local dentists, we brought in Vermont Technical College, and several other folks to look at how we could support each other in meeting the needs of our community. Our initial thought and goal was that if we could support local dentists, that perhaps this is where we could find our solution. But because of the Medicaid challenges, the local dentists were not able to help in any additional way than they already were. We also became very excited about the use of dental therapists in the practice of public health dentistry. And you're going to hear more from Dr. Warren about that in a minute. I'm originally from Minnesota, and I managed a public health dental practice in Minnesota. And in my work there, I lobbied hard for the passing of legislation around dental therapists. And I saw firsthand the benefits of public health dentistry utilizing dental therapists. And I think on the medical side, it's really equitable to nurse practitioners or physician assistants and what they've been able to achieve with hospitals. So we really looked to some of that for the answer. When it became apparent to us that our local dentists weren't going to be able to be the solution that we needed, BMH and United Way said, okay, this is it. We have to take this into our own hands. We have to do something about this. And so we said, we're going to open a dental center. And the first thing that we did was create a business plan. And we worked with Brattleboro Development Credit Corporation to help us develop that business plan. United Way hired a grant writer. We knew that we were going to need funding to get this off the ground. And the real linchpin for us was when a private practice dental center was looking to expand their operations and move into a bigger building and purchase new equipment, reached out to us and said, we have this dental equipment that we would like to donate to you. We know you're doing this good work and we'd love to donate this equipment. Do you want it? And we said yes. It was about 4 operatories worth of dental equipment, including chairs, handpieces, restorative equipment, an autoclave, valued at about $100,000. And it wasn't everything, but it was the vast majority of what we needed, and it really put us over the edge of, you know what, this looks like we can actually do this. And so with that said, we opened a dental center, Windham County Dental Center. Initially, when we set out, we said we'll open this dental center in 2 years. We were very happy to be able to report that we opened this dental center in May of this year, well ahead of schedule, again, indicative of the need that our community was facing. So these are some photos of the dental center. You can see the chair that was donated to us, one of 4 in excellent condition. The picture of the staff, our dental hygienist and our dental assistant, and then a photo of the building. And the building is an interesting piece of this dental center. The building that you see here is on a main drag in Brattleboro. It's on a bus line, and most importantly, it's on the hospital campus. And that's a really important part of our vision and our mission, is to help integrate dental care and medical care. I think so often we forget that the mouth is part of your body and plays an important role in one's overall health. And the more we can think about treating the whole person, whether it be dental care, behavioral health, medical care, all as one, I think the better off that we're going to be. In terms of our structure, United Way is the lead entity and operator of the dental center. They employ the dental staff, which is made up of a hygienist, a dental assistant, receptionist, patient advocate. The hospital employs the dentist, and that was a really important piece to us as a further extenuation of ensuring that medical and dental care were united, and also so that the dentist could be a part of the medical staff and have close working relationships with physicians and medical staff colleagues for cross-referrals and cross-care. Our goal is to hire the first dental therapist in the state of Vermont. We're very excited about this new resource in public health dentistry, and we would like to be able to utilize this resource to increase access to care for our community. And BMH donates the space back to the United Way in the Windham County Dental Center so that it's in-kind space, free space to the dental center. The vision primarily for the dental center is to serve adults who are on Medicaid. That's kind of our first and primary focus because of the great need that our community has shared with us. In addition to serving adults on Medicaid, we will also provide care to uninsured patients. We have a charity-free care program for which patients can apply, as well as a sliding scale discount program. And those are based on the patient's income levels and the federal poverty guidelines. We work hard to meet the critical and unmet needs of our community, doing so in a timely manner. And as I've said before, working to integrate medical and dental care, as well as utilizing new resources such as the dental therapist. Funding for this dental care, given the Medicaid reimbursement challenges and given the challenges that public health dentistry faces, will never be self-sustainable. We will forever be working to obtain grant funding to subsidize the cost of this dental care. And this is a list of the funding that we've received to date, so $330,000 to date, a number that we're very proud of in our work in applying for grants. A big piece of this came from the Thompson Trust, who donated $150,000 to us, and that's per year for the next 3 years. And that goes to providing the cost for the dentist and staff and equipment necessary to help provide care. That was a big piece for us. Thank you all. I'm going to turn it over to Carmen.
Thank you for attending. I hope everyone can hear me. So I'm going to start with the mission of United Way. It's to improve the lives by mobilizing the caring power of our community. Remember those words. We have a vision to have the greatest positive impact on the quality of life in Windham County as defined by the needs and priorities of stakeholders within our community. Remember that. How did this whole thing start? Some of the things you're going to hear from me, Ailey's already pointed, but I think having a different perspective where we were coming from and how this partnership came to be. So in 2009, we completed a community assessment similar to what hospitals do. You do a health assessment. And in that process, the community members came up with specific goals that they wanted to see happen in our community. One of those goals was that all people receive preventative and ongoing dental health care. This was in 2009. And I always feel so privileged that our community knew so early on that this was important. And we didn't know how we were going to get there, but we had it as a goal. So in 2011, we partnered with some local dentists, and we did adult dental care day. Since that first year, in the first year, we saw 184 patients, and about $85,000 worth of free services were given by 6 practices to volunteer their time. We had a triage at one of our centers, and we provided transportation. That's a huge need in our community, and so we transported people from the triage center to the practices. The last time we did the dental care day was in 2018. I'm glad to say that was so much work. And over that time period, we served over 1,000 patients and provided over $524,000 in services. In 2016, in partnership with BMH, we began to have a community conversation. And the conversation was, what's it going to take for members of our community to get dental care when they needed it, not just on that one day a year. United Way is in a unique position because we have so many different relationships. People that know me know that's my favorite word. We have relationship with the hospital. We have relationship with nonprofit organizations. We have relationship with dentists. We have relationships with businesses. We're not the typical nonprofit that kind of just works in the nonprofit world. We move all around. The Vermont Department of Health, community members, etc. So when we pulled this team together, we had a lot of people come. The early conversations around this took many forms and touched on many ideas, such as, would it be a good fit for the Brattleboro Walk-in Clinic to take on and with support expand on that? Would local dentists be willing to accept Medicaid if there was some kind of support system to assure that the patients could show up and meet some of the barriers that so many of the patients would have? Is there a practice that could expand to take Medicaid patients? We had many, many meetings, many conversations. We learned a lot. And the discovery was that none of those things were going to work, but we was not going to stop us. We were determined, we in the hospital were determined that this was going to happen. So we moved to what would it take to open up a dental center? We had this committee that was coming to these meetings were then divided into two subcommittees. We had the business plan committee and the sustainability committee. This is when all those relationships that we built since 2009 around this conversation came to full fruition. BMH provided the space. Now we had some place to put the donated equipment in the garage. BMH hires the dentist, and we contract the person out. In this case, it happens to be Dr. Rule. The beauty of that, I want to expand on that, is that we see a lot of children that their conditions of their mouth really requires them to have surgery, so he has to go into the OR. And that's, from our perspective, that's such a key point to be able for him to have that privilege of using the OR and really taking care of the teeth of these young members of our community. We had donations from construction companies. We had banks that helped us with the business plan. Then all of those things, when they were all put together, we had to do some really fun stuff, like register with the state, complete all the job descriptions. We had to hire a dentist, a practice manager, a dental assistant, a dental hygienist, determine every single one of those staffing needs, decide which company was going to be our supplier, find an IT. Everything had to be decided upon because we had nothing other than a building and donated equipment. We also had a panel, and it was used, and it broke, and we had to get that repaired. We had to set up the offices. We had to set up the operatories. We had to do a lot of training on the software. We had to put up curtains, order cleaning supplies, set up the labs, phone system, and so much more. But what we discovered is in this process how dedicated every single one of those staff members has become. They own this center as if they have been working there since 2009. And it's such a privilege to be working with the staff. As of the end of August, we have seen 172 patients. We've had 345 appointments. We have seen members from every town in Windham County except for 4. 934 services have been provided to 172 people. Majority of that, unfortunately, is extractions, but we will be turning that curve pretty soon. Hygienist appointments, full mouth treatment, and fluoride treatments. We're excited about the kids coming in and getting their fluoride. When I wrote this, we had a dentist that was working 20 hours a week, but as of October, Dr. Rule will be with us 30 hours a week. We have 2 volunteer dentists, each working about 10 to 12 hours per month. And we have a waiting list of 46 patients that are in need of dentures. Why is the center different than most others? It's our partnership with the hospital. They have tremendous amount of knowledge. They have Ailey. We have Ailey. Our goal is to fill that chair. Whenever the dentist is there, we need a patient at that chair. So we can do what most other places do and blame the patient when they don't show up. When the patient doesn't show up, we take responsibility for those things. So we don't judge. We look to see what the barriers are. We listen to our patients. We know the bus route. So when the patient is making an appointment, we can have that conversation. And they know, and even at the end of the day, somebody might say, I need an appointment at 2:30, and we know that appointment is going to take an hour, but the bus goes by at 3:45. They know that we need to give them an earlier appointment because otherwise they will be walking home. So our staff knows this stuff and works, and their job is to eliminate barriers. We make reminder calls, many of them. We are now sending text messages through regular track phone to remind them to please to call. We treat our patients that they're our family members. We connect our patients with medical practitioners. We have a lot of patients that come in that do not have a primary care doctor, and because the hospital has centralized scheduling, they can be given one telephone number. Centralized scheduling is literally behind our building. And so those connections can be made. And when they come back for their next appointment, that's a follow-up. It's like, did you make your appointment? Are you ready with your practitioner? We listen to our patients. So sometimes kids come in, and in the conversation, you discover that it might be, they have two households. So they don't just get one toothbrush and toothpaste, they get two. We want them to brush their teeth, so we make it easy for them to have it at both places. We listen some more. A lot of listening happens. We also provide all of the kids that come in, because with the United Way affiliation, we're members of the Scholastics, and I didn't want kids to go home with a piece of plastic toy that they would just throw away. So every child goes home with a book at the end of their visit. And I'll share one story with you around a little girl that was probably 5 years old. And when the hygienist told her, you may pick a book, she said, is it gonna be all mine? And the staff was like ready to go into tears. So that here is a child that's come to the dentist, had a great experience, and she gets to go home with a book. And so different than what we're used to, where we have, kids have bookcases of books. This child has her own book for the first time. And it made us very proud to be part of that. United Way's mission, to improve lives by mobilizing the caring power of our community. And I think with what I've told you, you've seen an example on how that's been done in our community. Thank you.
So I want to start with a statistic. Because of tooth decay and gum disease in Bennington, there's more people in Bennington that have actually had a tooth extracted than there are people with a full set of teeth. So I want to say that again. There's more people in Bennington that have had a tooth extracted than there are people in Bennington with a full set of teeth, right? Pretty powerful statistic, and it's really one of the ones that's driven why SVMC launched a dental clinic. I have some other statistics in here, and given the interest of time, the late afternoon, I'm only going to hit a couple of them. The first is the aging of our dental workforce. So big problem, right? You can see that very soon, it is as tight as access to dental care is now. Very soon it's going to be even tighter. And one other statistic I just want to hit on, and this is this one over here, which is that emergency department visits to our emergency department at Southwestern Vermont Healthcare for dental issues is nearly double what it is across the state, and rising, as you can see. Now, these statistics are a little bit old, but this is what's available from Department of Health. So we launched a dental clinic in 2019, in 2018. It opened in January 2018. It was a certificate of need profit process. We had to go through the Green Mountain Care Board and everything else to get through. 5 dental chairs, x-ray, intraoral camera. You can see some of the bulleted items there with regards to our clinic. How big is it? We have 3 FTEs worth of dentists. And importantly, that statistic that I showed earlier about number of dentists and their age, notice the age of this young fellow over here, right? Dr. Russ O'Connell. Recruit from the New England School of Dentistry for us. So we're successful at actually bringing young dentists to your community if you were to launch a dental clinic, right? You can see the rest of the team, very, very important to be successful. The services, basic general dentistry for the most part. That's primarily what we do. One point that I want to point out is this last one here, and it was touched a little bit by Carmen and Allie as well, is that not only are we delivering dental care, but we're having that deeper conversation with the family, with the children, with the individual about their longer term oral health. Not just brushing your teeth, but other things that can impact their oral health, such as juice and sippy cups, which is well known as an issue for young children. So how many visits? 6,400 visits already. 45% are under the age of 18. We've had 65 patients from really our 5 anchor zip codes, but we've had over 100 zip codes represented in our patient population. It shows that people are traveling really quite far for dental care because it's not just a Vermont problem, it's a Massachusetts problem, it's a New York problem, and for us in the lower western part of the state, those other communities in other states matter. One issue is we are already, launched in January, so we're 18 months or so out, right? We're already full. We're booked out 4 months. We've had to close down the practice for accepting new patients except through our emergency department. So we're not quite sure what we're going to do, but it shows the issue at hand and the need for other solutions other than just us solving it. 45% Medicaid, 10% self-pay. Allie and Carmen already mentioned, or Carmen mentioned this point about the no-show rate, right? You're dealing with a very fragile population who's living chaotic lives and are trying to figure out how to just piece things together. It's very, very important that we try to figure out how to fill that no-show rate with other gaps. Other patients can come in and double book and triple book if we can, and our dentists are very creative about working the schedule to try to get that down. One thing that is also pointed out is that this is not a money-making venture. This does and will forever require a Southwest Vermont healthcare subsidy. It's just the nature of the beast. So something to think about if you're thinking about launching one in your community. We're working very hard on efficiency and we're working on growing the clinic, but it's just a challenge with regards to the mismatch between reimbursement and operating expenses. So in summary, oral health is at crisis levels in the Bennington area. Access to dental care is extremely limited and will become more so as more and those dentists retire. We launched a very, very busy dental clinic that's only 18 months old and is just busting at the seams. And really, as much as we've started our journey of solving the dental problem, and I say started, we're committed to actually solving it even more. So this is really the first of many steps we're probably going to have to take in this dental sphere in order to actually meet the community need. So that's the nut. That's the bolts. I'll pass it on to Dr. Moore.
All right, let me get my bearings here. So thank you again for listening to us today. So dental therapists, how many people in the room know what a dental therapist is? All right, that's good. That's more than I thought. So dental therapists were passed by our legislation in Vermont in 2016. We were the 4th state to add dental therapy legislation. And so when I first started at Vermont Technical College, I started in May of 2017. And this map was like bare. You had 4 states. You had Alaska, you had Maine, you had Vermont, and you had Minnesota. So in the last 2 years, we've gone from 4 states to 12, which is pretty remarkable and just shows how fast dental therapy is kind of growing across the country. So we don't have a dental school here in Vermont. In fact, we didn't have a dental school really anywhere in Vermont, New Hampshire, and Maine until a few years ago when the University of New England opened a dental program. So there was a shortage of recruiting dentists to Vermont. We do, however, have an excellent dental hygiene program. And so when legislation was being passed in Vermont, Vermont Technical College came to the table right away and said, we want to be a part of this. We want to offer this curriculum. So please, when it passes, we will find a way to provide the education. So the dental hygiene program director, Dr. Ellen Grimes, looked for grant money and hired me in 2017, and then my charge was to create a program. There wasn't a lot of examples. There was existing programs in Alaska and in Minnesota, but nobody had been CODA accredited. So CODA came out with their standards for dental therapy and said, here you go, figure it out, and you're on your own. So that's when I started. So CODA did some great things for dental therapy. They kind of said, all right, now we're going to come out with standards that make this program on the same playing field as all dental hygiene programs, all dental school programs, all residency programs, and that was really great. They set some standards. Vermont had already passed legislation that required that dental therapists in Vermont also have to be a dental hygienist, and they said that the program that we created, in addition to including dental hygiene, had to be a 3-year program. They did not specify what kind of degree we offer, but they did say it had to include all of the scope of dental hygiene, and it had to be 3 years on a basis. So we started, in addition to creating the curriculum, looking for funding, because Vermont Technical College doesn't have any startup money to do that. And so we first passed the program through our Board of Trustees in March of 2018. That was approved. And then we got a HRSA grant for $1.6 million last September, which was really essential for us to be able to start this program. So in terms of our timeline, we also received funding from the W.K. Kellogg Foundation, Community Catalyst, and then we have a small grant from Dental Trade Alliance in addition to our HRSA grant to start the program. But we're still searching for some more funding. So this is our education for what we call our advanced standing program. It's 4 terms. And that's after you complete a dental hygiene degree, you can come in the fall and graduate the following semester with a master's of dental therapy. You can come in with an associate's degree or a bachelor's degree, but you do need 92 credit hours. And so our hygienists that are already trained come in, they're on site for those first 3 terms, and then that last semester we send them out into the communities at externship sites where they're doing additional clinical requirements until they graduate in December. And so our prerequisites for that program, this just talks about that. It's just all the hygiene requirements plus the 40 credit hours of general education requirements that are required by Vermont Technical College. So if a student doesn't have a bachelor's degree, they come into our program, they're awarded a bachelor's degree and a master's in dental therapy in 4 terms. We also have the standard CODA requirement for our 3-year curriculum. So someone could come to us with little or no college education, be educated 3 years year-round for 9 terms, and graduate with a master's in dental therapy. And that includes all their dental hygiene education and their dental therapy education. So 3 years. So that we anticipate to cost around $112,000, the tuition and fees. The advanced standing program is about $50,000, so the one I just showed you before that. And let's see, we did a cost return on investment for students thinking about going back to school, because we anticipate that the most likely student to enter the program initially will be a dental hygienist. So we found that it was cost effective for the salary that they would be making to continue to go back to school to the age of 58. So we decided on a number of 12 students total in the program. Based on the CODA requirements for supervision, I can take 10 dental hygienists as a max number, but I can take 2 more in the traditional track, and I can have any sort of combination thereafter. So if the population over time changes to where we've educated a majority of the dental hygienists in Vermont, I can take a traditional student over time as well. We don't have an in-person interview right now in our hygiene program. And we have found that even though our hygiene program right now accepts 22 to 26 students. Last year and the year before, we've had over 50% attrition, which is unusual. And so dentists in Vermont are really lacking dental hygienists as well. So we are trying to make sure that the tuition process is changed so that we are retaining these students. We expect, based on other programs, that we should have a 90% retention rate for these students. So this is just kind of going along the timeline of milestones that we've had as we've created this program and what we hope to do. So over here you can see I want Ailey to have the first dental therapist in Vermont. I was hoping that they would come from our program, but now we would just really love it if we could get a dental therapist from anywhere else in the country just to start practicing dental therapy in Vermont. We do think that even though the legislation in Vermont has required that a dental therapist graduate from a CODA accredited program, I was in the rulemaking process with our Board of Dentistry for dental therapy, and they do think that just as long as maybe a Minnesota grad from dental therapy, they would deem that curriculum the equivalent and we could get somebody certified. We just need someone to move here to Vermont. And Vermont has nicer winters than Minnesota, so they should come. So we got the Board of Trustees to accept our program, and we're looking for a little more funding. That HRSA grant was really important, so our goal is to start our first class in the fall of 2021. And this just gives some data about what's been going on with dental therapy in Minnesota and Alaska, which is really the two states where we have data from. And these both have been saying that roughly whether the Alaska model is the lower model and the Minnesota model is the upper model, basically a dental therapist costs their employers less than 30 cents on every dollar of revenue that they generate. And these are basically a big breakdown of the services they provide. So a huge amount of preventative services, a huge amount of restorative services, and then over here we also have our exams, which is huge. We can't have dental hygienists doing exams, and those are really important to start the process and offer more services for the oral health field. So the whole purpose is to increase access to care. They reduce wait times. They reduce clinic overhead times. Overall, clinics in Minnesota who have hired dental therapists say it's not just that we're now having another provider that we can open up access to care and decrease overhead costs, but the dentists are more productive, everybody's more productive. It increases the productivity of the whole team. So they find that these clinics find that they're not only able to hire more providers, but the cost that they're bringing back in terms of revenue has increased for the whole practice. This was a study that just came out by Donald Chi. He did a 10-year study in Alaska and the native population about what was happening with dental therapy. And they found that it was reducing the extraction rate for children. It was definitely also decreasing their general anesthesia rate, adult extraction rate, wait times were going down, and they even have returned to these communities where it was almost impossible to ever find a child that didn't have caries when they came to the clinic, and now they have children who are caries-free, which is just kind of amazing. These are just a small snapshot of the scope of practice of dental therapy in Vermont. Primarily, they can do all the functions of a dental hygienist. They can do all extractions on primary teeth, which are children's teeth. They can do all restorations for adult and children. They can provide pulpotomies, which are baby root canals, and stainless steel crowns on primary teeth. They can administer nitrous oxide, and they can diagnose and treatment plan, which is a huge thing in terms of access. So the requirements for licensure in Vermont is that they must graduate from a CODA accredited program or the equivalent in both dental hygiene and dental therapy. They must have their dental hygiene license when they apply, but when they renew their license, the state only puts the burden on renewing the dental therapy license. The CDCA exam is currently the live patient clinical exam that dentists take, and the dental therapist will take that exact same exam for the scope of practice of the dental therapist. So they will be required to pass the same one. All oral health practitioners in Vermont take a jurisprudence exam, and then there's an application fee. And then there's also a continuing education requirement for all three professions in Vermont. These are just an example of different locations that dental therapists would increase access in. Of course, they can practice in traditional private practice clinic settings, but hospitals, federally qualified health centers, Alternative practice settings, I think, is really essential for dental therapy. It's not really ideal or efficient for the dentist to leave the office to go to nursing homes, to schools, on a mobile dental van or anything like that, where dental therapists, they could totally be part of a practice and practice in the traditional setting a couple days a week, and then make it to a nursing home, make it to a school, make it to people where transportation is so hard, they can really make those visits worthwhile, and then refer back to the practice anybody who would need services provided in the office. Another part of our program I mentioned was that last semester of that advanced standing program, our students are 100% off-site for 12 to 15 weeks. And these students would go to these externship sites, which we're hoping are community clinical settings, where they have a diverse patient population and they can do everything in their scope of practice. So I've already taken them through VTC and they have completed competencies on live patients and in the pre-clinic for everything in their scope of practice. So I'm not sending them out saying, okay, go try this out in the community. They already have completed these competencies. And then they go out and they work in the community and they test these skills. And my goal is to send them in pairs so it's not a burden where they'd have to provide an assistant or anything like that. They would be pretty self-sufficient. They do need a dentist on site willing to supervise them. And that doesn't mean that's a huge time commitment. It really is that in case they have a question or any sort of issue, they have someone they can go refer to. And this is something that's done in dental schools across the country and was sort of done on a limited basis until the last few years when dental schools kind of were like, this is a really good idea. If we send our dental students out into these rural areas, they might actually go practice there when they graduate. They might like it, and they're certainly going to be exposed to a different community and a different patient population than they are at the school. So this is really important for recruitment. It's really important for their experience and their education, and I think it'll help recruit both from the community and back to the community. The other thing I can tell you anecdotally is we started our own program at Vermont Technical College recruiting an extern, a dental student from the University of New England this past year. And we had to do essentially kind of what Carmen did, set up our clinic to provide more than just hygiene services. So we had some stuff set up, but it was a whole lot more to be able to offer the full scope of dental practice and then to hire a dentist who wasn't delivering care themselves, but just supervising the student. And it was still profitable. And we had no idea what we were doing, and we couldn't be more inefficient with the way that we did it. So I will say that that was really good. We plan to continue doing this, not just because we wanted to offer more services and expand care in our area, but having dental students now work with hopefully our dental therapy students will expose that kind of unique partnership so that they might be more likely to work together once they're out in practice. In addition, we have a local dentist in Chittenden County who practices primarily Medicaid and said, oh, my dental extern from the University of New England netted me $40,000 last year. So this is a sustainability for anybody who's interested in hosting an extern. The procedures that the dental therapy students do for the Medicaid population, it's, most of those basic restorative services that are covered by Medicaid, a dental therapist can do. So I think it's really important. In summary, so we talked about them increasing access to care, working in different practice settings, expanding practice, the extern program. We really want the students to be all over the state so that they can go back to the communities. Because one of my biggest concerns for dental therapy is, in the end, if the dental therapists are snatched up exclusively in private practice, are we really doing anything to solve the access to care problem? Vermont in their legislation said they don't have to practice for the underserved. They don't have to practice in rural areas. And eventually, when the dental community understands that dental therapy reduces their overhead costs and expands their access, everyone is going to hire a dental therapist. They're just going to love them. So we want them to go to areas where they're needed the most. And I think that's it.
So to close this out here, why should hospitals care about dental care? And there are a few reasons. One, there are patients. They're the patients that hospitals care for every day, and this is a big part of what they need. Two, it's what we end up seeing in our emergency rooms, which is not the right use of funding and resources and valuable ER clinician time. And lastly, it's because untreated dental care can lead to serious medical problems. It can lead to heart conditions. It can lead to exacerbation of diabetes. And if untreated, it can lead to death, as we've seen with particular patients who have had untreated dental infections. And so it's something that we must look at. The other thing that I want to add is that we talked a lot about the Medicaid reimbursement challenges, and we've had some exciting legislation that's going to go into effect in January that increases the cap, and that's great and wonderful, and we need that, but that is not going to be the answer to this problem. We really need to think about a new model of care, and I think that's where hospitals get involved, and I also think that's through the use of new practitioners such as a dental therapist. And so I urge hospitals, as they think about if they have this need in the community, how can they also help support dental therapists? Vermont Technical College, to get accredited, needs to have dental centers who are willing to sign up to host dental therapists as externs. And so if this is something that you are considering, I urge you to consider being willing to accept a dental therapist. Lastly, how can this model be replicated if you have a need in your community? First and foremost, identifying is unmet oral health needs something that your community is facing. For those hospitals who are lucky enough to have a federally qualified health center, those needs might be met. But for hospitals like Brattleboro Memorial, where we don't have that, we had to take the matter into our own hands. Look at existing resources and existing partnerships that you can leverage to help meet these needs. Next, build your business plan. Every grant that you apply for is going to ask you what kind of staffing model do you want to have, what's your payer mix going to be, what's your vision, how do you continue to fund this? And then consider the use of dental therapists, as we've talked a lot about. The fight for dental therapists, I think, is pretty similar to the fight that hospitals have gone through with accepting nurse practitioners and physician assistants. There's a lot of talk from dentists about what does this mean for their licensure and their liability, and we need dentists to be passionate about this new model of care as well. One of the things that we've done in our dental center is we write into the contract for any dentist that we hire that they must be willing to enter into a collaborative agreement with a dental therapist. So we share that vision early on with them in the interview process and ask, are you comfortable with this? And are you willing to have that collaborative agreement? And if they're not, then they're not the dentist for us. So that's an important part of the work. And then really get started. I think it's important to not let perfection be the enemy of good, and try it, see what works, have that constant feedback about what's not going well, and tweak it and go from there. So thank you all for attending our presentation today, and for hearing about our passion and the work that we're working on. And I will open it up to any questions that you all may have.
Hi, it's Tom Day from Southwestern Vermont Medical Center. So for dental therapists, what is is there a supervision requirement that they have?
Yes, so in Vermont, the way the legislation is written is once a dental therapist graduates from our program, or any program, they need 1,000 hours of direct supervision. Direct supervision means the dentist has to be present in the office, not at a different site. After those 1,000 hours, the dental therapist and the dentist can be anywhere, as long as there's a collaborative management agreement where the dentist has written what procedures they allow the dental therapist to do, and which should be everything within their scope of practice. Anecdotally, in Minnesota, the dentists that we talk to that hired dental therapists say there's a 2,000 hour requirement in Minnesota, and they say after 300 hours, I'm really sick of the whole thing. 300 is really all that's needed.
So after that, they can practice on their own? And what's the typical salary requirement for a dental therapist?
So right now we really only have Minnesota to go by, and for all the research that I've done, I anticipate that a dental therapist would take about $10 more an hour than a hygienist would from the start. But there's lots of different models that people choose to pay as. Some FQHCs choose to go strictly on a percentage of production. Some choose on an hourly basis. It really depends on how the practice is structured and what they're doing.
Just one other question for Windham County. Fluoride treatment in the water system, is that in place? So Bennington and Windham are two of the counties in the state that don't have it.
That's right. And why the fluoride treatment in the dental center is so important.
Okay. And is there a county-wide initiative to revisit this?
It is certainly definitely being looked at. One of the champions for this work sits on our advisory board and works with AHEC and is sort of helping to lead the charge to continue to have that be reviewed.
Well, thank you. Great programs that you highlighted today. I saw on the Southwest Vermont slide, and you may have had it on the Windham County slide as well, you're accepting commercially insured dental patients as well. How did that go with your community private practice dentists? Were they up in arms about that because you were competing with them, or not?
Yeah, it's a great question. Prior to launching our clinic, we had quite a few forums where we brought together the local community dentists to talk that through. And our overwhelming position was, we can't meet the community need, please open.
Same here.
And we do at the Windham County Dental Center accept commercial insurance. We know one of the big draws that we thought that we would have, and we continue to think that we will have, is being on a hospital campus, having employees come and seek access at the dental center at a location that's convenient for them to work it into their work schedule. But same, right? The local dentists they did not view us as competition. They actually refer patients to us because they know that they can't meet the needs in our community.
It doesn't sound like you had to really go out and market the program in either location. I mean, they're knocking down the doors.
Very much so. We do still work to get the word out there so that patients know that this access point exists, but I think probably for both programs, as soon as the doors opened, schedules were full. Yeah, right.
Yes, all we did was set up a Facebook page, and that's been a way that information gets out about opening and hours and stuff.
And the same at VTC. Now, most of the patients that come to the hygiene school all have dental homes. So we were thinking, okay, well, we can't compete and it certainly would be unethical for us to take patients from dentists in the community and start offering them dental services with this dental extern. And so we were really worried we wouldn't have any patients, but the school wasn't taking Medicaid before. And we opened the door and said, here, we'll take Medicaid patients. And now I have a huge wait list and I cannot meet the need.
So one of the questions I have is about pregnant women on Medicaid. They have unlimited until 60 days postpartum, is that right? So is there any priority that's given to dental decay or need in pregnant women during that window of opportunity?
I think there should be, for us being new at the school, we don't have any sort of policy on that. Mm-hmm. I was a dentist that provided care at an FQHC before I took this position. And so once a pregnant woman came to see me, we right away mapped out when that date would expire and scheduled as many appointments as possible in that time. But some of the barriers are those women also have transportation issues, they have childcare issues. So there were still ways where she may have scheduled a lot of appointments with me, but she didn't make them all. We weren't always able to get through a treatment plan because of that shortened timeline.
Yeah, and what about Windham?
I can answer that. So at our center, what we have done is we definitely give priority because we have that timeline. And we have a relationship with the Department of Health, and a lot of the pregnant women, that's going to be the first contact. So she sends them right over to us and calls and tells us they are, and we give them priority.
On the certificate of need, can you talk a little bit more about that process and how that came to be?
Yeah, so the Green Mountain Care Board's rules on certificate of need are published. They're well known. The process is also very well known and pretty arduous. I have to say our process with them wasn't too bad. It started to go off the rails a little bit at one point, but we were able to have pretty clear conversation with the Green Mountain Care Board and get it back on track. So the process took well over a year to get approval, and they were being nitpicky about things, and we were able to basically point out that their questions really had nothing to do with the need in the community or our delivery of care, and they were able to move it through.
So is it your sense that since they've cut their teeth on this certificate of need, do you think that could serve as an informed precedent for favorable consideration for other entities?
I would certainly hope so. I would certainly hope so. Yeah. Yeah.
So my name is Steve Gordon. I'm the CEO at Brattleboro Memorial Hospital, and we were really truly inspired when Ailey and I went over to Tom D and saw James and the dentist, and from that visit we were really motivated. I was also completely motivated to avoid Green Mountain Care Board and a CON filing, and it wasn't a real driver, but our relationship in doing it as this joint partnership with the United Way and Carmen's organization avoided that entirely. We donated the space from the hospital, as mentioned. We got contractors who I use at the hospital. I offered them the opportunity to renovate the space, and they gladly joined us. My Rotary Club in Brattleboro also joined us for some renovation and painting, although they didn't let me do much of that. But so we did avoid the complete regulatory apparatus, and how we have set it up is the funding from for the dentist, really for the employment of the dentist, comes through our parent corporation, through our endowments, through that. So it really doesn't hit our quote hospital budget. So there was some advantages as to how we set it up, but it's really the advantage for these two organizations, the United Way and the hospital, really created a real buzz in the community and expanded greatly our visibility in this to provide this service and the opportunities for the grants. So all those grants that were in process and have been approved, they love seeing the collaboration between the hospital and United Way. And very unique situation, and one which I think is going to be very successful in the future, because as James said, and as Ailey will tell you, this thing will never make money. But we've got to be always on the list for grant money and continuation of the services throughout the state, and hopefully the state will be doing some more recognition reimbursement-wise through Medicaid. But you know, Tom really, I think, was one of the first hospitals, his hospital, to get into this water of dental care, and was pretty inspirational to us. And now you have a different model, because our communities are a little different. And so there's no playbook for this. And it is fairly unusual for a hospital to, especially small community hospitals, neither one of us are critical access, but we're still small in the big scheme of things, to really look at this. But it is totally related to medical care. And when we brought this in front of our medical staff, it's the first time our medical staff actually applauded. And Tom will know that. It's always difficult to get our medical staffs to really appreciate this. And then just this past week, Dr. Rule, who's our dentist, stood up and gave a presentation as to the status of the program, and he thanked the medical staff and his peers, because that's the other piece, is he's a member of our medical staff as a dentist, and he thanked the physicians, especially primary care, for accepting these patients who not just come in for dental care, but they need medical access. So, and again, he got another ovation. So it's really something that resonates with our clinicians here at the hospital and at Brattleboro.
One other quick, I guess, postscript here is that not directly related to this initiative, but the bigger issue. Bennington County is not a fluoridation county in the state of Vermont. It's been brought to referendum 4 times and has lost 4 times. So we have met, and I have committed that the hospital will lead the initiative this time to get it through, which is going to be, we're going to actually put together a true campaign with a lot of resources to work on trying to get this through, because certainly it's one of the biggest public health benefits at a very, very cost-effective rate if we can get that through. And all the dentists certainly are supportive. So I expect that there'll be around 5 coming through that hopefully will get over the top.
Michael Costa, Northern Counties Healthcare. Thank you for a great presentation. Just a couple quick questions. I know that you made the point several times that this is not sustainable on its own. It requires subsidies and a real commitment to finance it. I guess my big picture question is, if the state truly went to a capitated payment model where you'd broken the link between when people come in the door and when you get paid, would this be sustainable? Would you be able to reduce costs in other aspects of your business to be able to pay for this properly, or does it always require outside funding and fundraising? That would be my first question.
Dental care really plays the bass notes around so many other health issues, be it diabetes and even, you know, many of the behavioral health issues, self-esteem, job readiness, employment, all can be linked to poor, or unlinked or decoupled with poor dental care. So the answer is maybe. The problem with capitated payment, the way Vermont is rolling it out, and this is a much longer discussion, is that it's based on historic payment. So you're adding something, so you're adding an expense, hoping to reduce the amount of healthcare utilization so that you have spare money that you can pay for the additional expense. It's a little bit sideways when you start running the math that way.
And I would agree with that, and it really creates a problem for any investment that's going to take many years to pay off. I guess my other question would be, as our company started a health center in Orleans, Vermont a couple years ago, one of the real challenges that we've had is that since that community was without dental services in the Medicaid population for many years, the acuity level of patients is so high that productivity is very low, and our providers are suffering physically from the level of effort. And so I wanted to know whether you have seen that and what, if anything, you've been able to do about that.
I can answer that. So you're absolutely correct. One of the discoveries that we've had at our center is the amount of care that each patient needed. And so we have to balance that. We also have some volunteer dentists that come in, so that helps relieve some of the regular staff at times. And one of the other aspect of that was the emotional side. After 2 weeks of being open, I said to Ailey, I need to call in a therapist to come and meet with the staff, because the term was, the dentist used the term, I feel like I'm in the war zone of dental care. They saw one of these cases a year in their private practices. But when they see it and they have 8 patients a day, 7 patients a day, and every single patient requires this kind of, I had staff in tears around what they were experiencing. So that's something that you need to be aware and a support that you have to give to your staff. And it is quite a challenge.
I think it's a very excellent question, one that would really require a whole overview and review of how we reimburse services and making sure that dental care is included, because right now it isn't, and it's not part of a capitated payment program. It wasn't part of the Affordable Care Act, and so it's really a shift in the mindset of our healthcare community.
As a dentist working at an FQHC, when you see the Medicaid population and the need, typically a patient would come in to see me for an extraction because there was an infection. They didn't really think of their Medicaid benefit, even though Vermont had a very high Medicaid benefit, as traditional dental insurance. They weren't coming in for preventative or any routine care. We would do that with our children, but the adult benefit wasn't thought of that way. So I'd get a patient and I'd say, okay, well, you have 10 other cavities to treat, but your Medicaid benefit after I extract this tooth might cover 1 or 2 more. And so it was like I could say I could treat lice on one side of your head, but then I was just going to leave it the rest. So as a provider, I felt like I was just flushing money down the tubes by giving them 2 restorations and an extraction and saying, come back in a year when you have your benefit again. So hopefully the increase in the cap. And then we also have another tool in the toolbox. We now have silver diamine fluoride, where we can now apply this silver diamine fluoride to decay in the mouth. And instead of saying, I'll see you next year and I'll have to extract that tooth too, I can arrest decay and we can work through a treatment plan, and I'm not flushing dollars away. And that's something that both the dentist, a dental therapist can do, and even in some cases, the dental hygienist can do.
Excellent. Well, you guys have been a great audience. Thank you so much for coming and listening to us, and have a great rest of the conference.